Good evening, and welcome to everybody who's here and has signed on, and a particular welcome to Ruth. As you've seen in the blurb, Ruth has had a distinguished career looking at questions of health policy. For 13 years, she's been attached to the Myers JDC Brookdale Institute in Jerusalem. She's been a representative in the European Observatory looking at health policy, and it was in that capacity that she came along and spoke to us during the COVID-19 pandemic on the subject of the early phases of the pandemic. And she's kindly agreed to talk to us tonight on something that is last time we allowed about 6 months to elapse before we asked her to come along. This time, as we all know, we've only allowed about 10 days to elapse since the period that she's going to be talking about. One of the advantages of having Ruth come along is that, of course, she represents Israel in a general sense at the European Observatory, but she is part of the institute in Jerusalem, where they are not talking about from the point of view of one of the Kopot, from the point of view of one of the universities, from the point of view of one of the hospitals. They're talking about the global picture in the Israeli healthcare system and looking at it in an integrated kind of way. And that's a great advantage of having her here, because she's able to present that kind of overview, which is something that I think all of us really want and need. So I'll hand over to her and look forward to her presentation.
Okay, thank you. And I will just say a few words about myself before we start. So I am originally from Brazil, and I have made Aliyah when I was 18, many years ago. I've lived in Israel for about 25 years, and now I am in Germany, in Berlin. I came here to finish my PhD 4 years ago. And so I'm still affiliated to Brookdale, and I work there. And I also work here at the Berlin University of Technology. And as David mentioned, I am the Israeli representative at the European Observatory on Health Systems and Policies. And while my body is here in Berlin, my soul and my mind is currently in Israel. And it's a bit difficult to work and function these days because it feels like I'm divided in these two worlds. And that's why I decided to create this presentation, because that's more or less the only thing I could do during the first week after the attack. And also, before I present, I would like to mention that we have to acknowledge that there is also a lot of pain and suffering among people in Gaza, and the healthcare system in Gaza has been dealing with the challenges as well. But I'm not in the position to talk about what's going on in Gaza. So today, the presentation is about the challenges and responses of the Israeli health system during the first days of the attack from Hamas. And let's get started. So I would like to first begin with a quote from the CEO of Soroka Hospital in Beersheba, which was the hospital that received most of the injured people on Saturday. And he said, "It was a day that no one in the Western world knows how to prepare for. It is not an event that the Western world is familiar with, nor is it an event that we are familiar with." And this is, I think that this shows the strength of what happened there and how they coped with this. So as a background, just to mention about the Israeli healthcare system, it has 4 competing health plans, which are nationwide, and they are responsible for providing services to their members. So they're not only payers like sickness funds, they are also providers. Some of them own hospitals, all of them employ physicians, so they do more than just pay for services. Israel has a strong primary care, which is well connected to specialist care, but the system is stretched. And you can see here in these two charts that Israel has lower than average public funding, rates of workers, and hospital beds. And with this stretched system, Israel had to cope with this attack from the Hamas that has been ongoing since 7th of October. So the immediate challenges that were created by the attack were clearly in the hospitals, because there was this sudden surge of patients, mainly needing trauma care, orthopedic and burn surgery, and mental health. So here you can see this chart that shows new hospital admissions, and most of the patients arrived on the 7th and on Saturday and Sunday. But this was very unusual. 100 patients arrived to Soroka Hospital between 9 and 10 a.m. And during that day, Soroka received about 1,100 patients. Just for you to have an idea of the dimension of this event, the second hospital, Barzilai, was about to make an exercise with the World Health Organization, where they would train how to prepare for a multiple fatality event, and they were preparing for 100 patients per day. And here we had 1,100 patients in one day. So this is the dimension of the scale of the event. Within 4 days, about 3,000 patients were taken to Soroka, and another 440 were taken to Barzilai, and from there they were moved to other hospitals in the country. In the same day, on Saturday, Barzilai Hospital was hit by 2 missiles, and some surgery rooms were shut down. So this was the initial shock. But we know that the Israeli health system is prepared for emergency. They have emergency plans and exercises that they do on a regular basis with good communication channels. And in fact, COVID left a legacy of fast action throughout the decision chain, because many of the responses that you will see now were actually done also during COVID. So there are a lot of parallels and also some differences with COVID, and I will highlight the similarities and differences of this event with COVID. So first, there was a good communication between pre-hospital and hospital care. Hospitals were called in advance by ambulances and could prepare to receive patients. But this time, many patients arrived by themselves and not with ambulances, because there were people coming and bringing injured people from the field, and not all the patients were taken by ambulances. So while the communication was good, it was not enough. Then a second step was the communication between hospitals. So all the patients were taken to the hospitals in the south, so mainly to Soroka Hospital, and there they would undergo an initial screening, and those that were in conditions to be transferred to other hospitals were transferred to hospitals in the center of the country, but that could be done maybe more smoothly. There was another communication channel that worked pretty well, which was between the hospitals and the health plans. And as soon as the hospital understood that they were receiving a mass casualty number of patients, they discharged all the non-war related patients, and these patients were sent to outpatient care, meaning that health plans had to develop very fast hospital at home or continuity of care in the outpatient setting. So either at people's homes or in other settings like rehabilitation or nursing homes and this kind of places. There was also a good communication between hospitals and local authorities, and hospitals sent information to the local authorities, who then notified families about the hospitalized patients, because a lot of families were looking for their members that were in the south, and there was no enough information of what happened to them. So this was also done, but probably not enough. Now, the second topic I want to mention is the health workforce for acute care, because this is the backbone of the health care, right? If you don't have enough workforce, there is no treatment, but so far there are no shortages. Still, they faced a lot of challenges. So many health workers were called to military reserve duty and were taken actually from hospitals and also from the community care and ambulatory care. So the workforce was reduced because they had to serve in the army. It is also difficult to shift workforce from other clinical fields for this event. So unlike COVID, where workforce from surgery wards could be deployed to work in the internal medicine wards or in COVID wards, here it was impossible to shift internal medicine workforce to surgery and trauma care, because this is highly specialized care, and workforce from other clinical fields cannot fill in this gap. So this is a difference with COVID, for example. In addition, workers were functioning under emotional distress, meaning that their family members were disappeared and were injured. Some of the workers themselves were in the shelters at the beginning. Some of them were injured. So it was a very stressful situation, and they had to work under a lot of pressures. So the responses included many, and for example, the hospital workers that were working at the hospital just kept working longer hours. So instead of going home after a shift, they stayed much longer and worked extra hours. And this is for now on a voluntary basis, because it's not yet clear if and how these workers will be paid for the extra hours. And still they are doing that. About 800 military medics and medical students were recruited to hospitals to support the surgeons and orthopedic and trauma and burn workers. In parallel, students and other health professionals were employed temporarily in hospitals, in the clinics of the health plans, in ambulances and nursing homes, because, as I mentioned, many of the health workers were called to the military, and we needed to complement this workforce. Health workers also voluntarily provide outpatient care, either in person or remotely. And this is also so far unpaid, and it's not yet clear if they will be paid. So there are a lot of health worker force volunteering to provide care for the needed patients. Health plans are providing care for all residents, even non-members. So for example, Clalit is the biggest health plan, and they have most of the clinics in the south of the country, and they are providing care also for members of other health plans, because it's more difficult for them to reach their own clinics. And currently they are doing that again in a voluntary base, because it's not clear how other health plans will reimburse Clalit or vice versa. So everybody is mobilizing to give the care as needed, not necessarily as determined by law. So this is the situation of the health workforce. The next big challenge is the mental health. And now Israel is in trauma. The whole country is in trauma. The population is in different levels of emotional trauma, and it's very difficult to estimate the needs for mental health care. It's clear that people that were in the south and were present during the attack and soldiers are under mental health stress, but other people were also exposed on TV, on radio, they have family members. So the need for mental health is not yet clear. It's clear it's very big, but for now it's difficult to estimate. So hospitals are preparing and providing mental health care to patients and workers. Health plans are operating emergency mental health hotlines for initial care and screening. And the hotline established during COVID was repurposed to help children and parents that were exposed to the atrocities. Mental health NGOs, so non-governmental organizations, increased their activities. And also local authorities have established hotlines with care provided by volunteers. The problem is that there might not be enough mental health professionals to meet all the needs of the population. And this is something that will still be a need on the long term. And there are other unique challenges in this event that the system had not seen ever before, which is related to the quote that I mentioned here, that doctors and forensic experts are still working to identify the bodies. About half of the bodies were identified. They are all wrapped in plastic bags. There are obviously adult bodies and children's bodies, but the vast majority of bags are misshapen. And this is a big challenge. It also shows the atrocities that happened in the South. It also shows that there is still a lot of uncertainty and people that don't know what happened with their loved ones. So many family members came to the hospitals in search of their relatives in the first days of after the attack. And some families are still waiting for a response of what happened to their family members. There is a very big shortage of physicians because there is a huge need to identify a massive number of dead bodies, issue death certificates and burial licenses. And there are physicians volunteering in this task. They came from Israel and from other countries as well, like the US. There is something interesting that happened is that the demand for routine healthcare did not increase. And similar to COVID, patients that are not related to the event refrained from leaving their homes because they feared bombs. They understand that now all the efforts should be given to the war-related patients. So there is a reduced demand for elective care. In parallel, the country and the health system is preparing for threats from Hezbollah coming from Lebanon and Syria. So hospitals moved entire wards to underground protected areas and parking lots. It has happened not only in hospitals in the south and in the north, but also in the center of the country. Most of the elective activities in hospitals were put on hold to reserve capacity for emergency care, and this happened mainly in the north and in the south. The hospitals in the center are still functioning, but they are also preparing themselves to receive patients from the north and from the south if there is need in the coming days. Hospitals also initiated prevention measures against cyber attacks because there were already some cases of cyber attacks in some hospitals in Israel. So they are preventing this kind of attacks that have higher chances of occurring during these days. The civil society is also very engaged and preparing. So there was a massive blood donation, and you can see here people queuing to donate blood. This is how a queue looks like in Israel. But it also shows the amount of people interested in helping and donating blood. And there was a similar massive human milk donation for babies that survived and their mothers didn't, or the mothers cannot feed them anymore. So the whole population is volunteering to help these families. We already know that there are long-term care needs, particularly in rehabilitation and disabilities and all related to that. So we have now some numbers of the IDF rehabilitation and disability needs, but these relate only to the physical rehabilitation and disability. We don't know yet the mental health situation, and there is still not clear estimate on the rehabilitation and disability needs of non-IDF, so non-soldiers. So these are the figures that I could gather so far. We have 1,210 IDF wounded that are being accompanied by the IDF Rehabilitation Division, which is a huge number. 329 of the wounded have already been recognized as disabled by the IDF. And it's not easy to be recognized as disabled by the IDF. And now they're doing that really quickly because these people need support and fast. Many of these wounded people were discharged to hotels while their homes are being adapted for accessibility because some of them cannot walk anymore. And the disability allowances will be paid for 4 months automatically without the need of medical committees, which is a normal procedure otherwise. But it's not clear from which budgets these allowances will come, because this is clearly a big new surge of disability allowances, and the country was not prepared with this budget. As I mentioned before, there are no estimates yet on mental health injured and disabled, so we don't know the future needs of mental health. And we know already that there is shortage of rehabilitation experts, orthopedic and neurological workforce, and there is also some planning of volunteers from abroad to work in hospitals. So physicians from other countries will be coming soon to fill this gap. But it's not clear for how long they will be in Israel and to what extent they will be able to meet these needs. And I think that we could mention the discussion and conclusions already, saying that the big challenge is the day after. So there is already an assessment of the first days of the attack, where we know that the health system was an island of stability in the chaotic sea. Many of the authorities were not functioning, but the health system could work properly. And now the big challenge will be the long term. What happens to patients the day they are discharged? How can we ensure continuity of care? How do we meet the increased demand for mental health and rehabilitation? So, for example, now we know that there are 4,400 new patients that need rehabilitation. This is a number that the system was not prepared for. How do we deal with backlogs and the waiting times for elective care that was put on hold? Waiting times were long even before this war. What will happen to these waiting times when the war is over? There will be clearly even longer waiting times, and this has a lot of negative outcomes to the health of the population. How do we maintain quality of care? How do we support health workforce to prevent burnout? They are working very long shifts. They are exposed to very difficult scenes and patients and situations. It's difficult to maintain workforce on a long term this way. And another big challenge is the financial sustainability for the health system in not only, but now we focus on the health system. Where do you find the budget to fill in all this surge of need? Is the government going to inject new monies from government funds like they did during COVID? This is not clear yet. There is no information about that yet. How will Israel cope financially with all the needs that are related to this war? This is also a question that there is no answer so far, no clear answer so far, and it will be a big challenge. So these are the main difficulties that the Israeli system is facing. They are coping pretty well for the dimensions of the event. And I just wanted to finish with a small prayer that we have peace soon for every people. And here I stop my presentation.
Right. Thank you very much. Thank you very much for very clear overview. The questions can come in through the Q&A and chat systems, which people can use to pose questions. If I could just start off by asking questions. You say that the standard, that the normal patient throughput and the normal care has the waiting times have increased and will increase as a result of all this. Is there in particular specialities, is there any information, for example, has there been delays in cancer treatment? Has there been delays in cardiology treatment? What are there any information about the kinds of things that the delays have increased in particular specialities more than others?
Well, so clearly the elective care was the one that was put on hold. All the emergency care continued being treated, even if it was not directly related to the war, because that's what the health system does. They treat first the urgent care, urgent cases. I don't know yet if there is a particular clinical field that will face longer waiting times. This is something I don't know yet.
Because kind of the measure in the UK always is used as the speed of cancer care. Our radiotherapy units, for example, and chemotherapy units functioning at the moment in areas like Sirocco and areas in the center of the country. Those kinds of care.
Yes. So all hospitals, during some days, all hospitals put the elective care on hold. Many have resumed elective care, but the hospitals in the north and the south are working with lower capacity for elective care. So it's not clear yet. And I think that this question is something that people in the hospitals would be more able to answer than me, because I have only this overview of the health system in general, less on what happens in the hospitals themselves.
The one question that gets asked of me every day and gets asked amongst the community here is about volunteering and about volunteering from the UK. One suggestion from Liz Lystone is that you could have virtual clinics handling some of the elective work from elsewhere. Another question put forward is that you might have the possibility of that no pediatricians are required, and you might also have the possibility that how do volunteers get administered? Do you know any of those questions you can help us with?
Yes, so volunteers remotely from their own countries to give elective care remotely would be something that the health plans should be organizing, because this would be probably for the ambulatory specialist care or primary care, not so much in hospitals or rehabilitation remotely. And this is something that the health plans would organize, because they have to give access to these volunteers to the medical records or to their system to register patients and things like that. So probably they will initiate these kind of initiatives. I think it's yet too soon for that. I know that volunteers coming to Israel are being organized by the Ministry of Health and by the military. So this is what I know regarding volunteers so far. I know that there are these groups of physicians that are coming in delegations, and this is organized by the ministry. They don't come alone.
So it's all done. It's all done to be by registration with the Ministry of Health. And
I understand, yes. But I can check on that and provide more information. And I know that the ministry is organizing a lot of volunteering delegations, and they are also preparing the system for the next days of the war that probably will come. So they are very busy organizing and preparing the system for more casualties and more injured. So maybe they are doing that in an organized manner through the medical associations.
Right. Okay, so now there's a series of very, very key questions about the process. And really the first one was how does the central control work from pre-hospital evacuation and then in hospital? You know, you've got your injured person or your injured civilian or military, and evacuation and then getting to the hospital. Where's the central control of that? Is it in the hospital? Is it in the military authority? How does that actually work?
Yes, so ambulances have contact people in the hospitals, in the emergency room, in the emergency and the surgery rooms, and the ambulance would contact this person, and the person would then notify the surgeons and the emergency room personnel. The military would also contact them. So the medical division of the army has this good contact with the hospitals as well. The problem, as I mentioned here, is that there were many injured people being brought by family members and by volunteers that just came to the area and evacuated injured people. So in this case, the hospital was not notified because there was no way of doing that. People didn't know, those that were evacuating the injured didn't know that it was possible to notify the hospital, and they were doing that also in a very urgent and fast manner. So the hospital was notified only partially by the official means, but all those people that came by themselves, in a way, just arrived. So not all the patients were coming in an organized manner.
Okay, one of the questions, of course, is the question of the relationship between the military and the security.
Yeah.
And the question of, kind of whether some of the people that are arriving at hospital are in fact part of the terrorist attack. How is that military and security, as it were, division negotiated? So
I don't have information. I don't have knowledge about terrorists coming to the hospital. No. I know that there were some terrorists that were treated, but then they were treated in the military setting, not in the public hospitals.
Right. So what is the military setting? What is meant by the military setting?
The military, they have their own clinics, and they were providing the care in these clinics, not in the public hospitals.
And if burn wounds, burn injuries, and fractures and those kinds of things would require care in hospitals, or could they be done also in military units?
Yes, everything they could do in these military clinics, they did. Yeah, there might be some specific cases that needed the hospitalization, but I am not really aware of it. And if there were these cases, they were very few.
Right. All right. So, what about the general population? Are there going to be different kinds of awareness and training for the general population? You know, it's a case that you always are looking at the current and looking at the past and preparing for it. And then when it happens, you realize you need to make slightly different preparations. Are those kinds of thought processes taking place so that people will be better prepared?
Yes, so people have always prepared their shelters at home, and there were a lot of notifications from the military for people to buy food and store food and water for several days. And people in the dangerous areas were notified not to leave their homes and the shelters. They do have this system of notifying people about the dangers. For example, it's forbidden to go to the beach because it's an open area and there are no shelters. But in terms of the health system specifically, people are being contacted by their own health plans, and health plans reach out to offer mental health support, for example, which is probably the most needed kind of support these days. They are reached out to give explanations on how to receive care in case you cannot come to your clinic, and many health plans are sending health workforce to areas where a lot of displaced people are living currently. So, for example, many of the residents of the south or around Gaza were displaced to the Dead Sea area or to Eilat, and all the health plans are sending health workforce to provide the care they need in these areas. So, of course, Eilat now has to cope with a population that is twice or three times or four times the size of the population in usual days. And so there is four times the need, at least four times higher needs of health services. So all the health plans are sending health workforce to meet these needs, and they are opening these temporary clinics in Eilat and in the Dead Sea. Physicians are taking care of people from all health plans, regardless if they work for one health plan or other. So there is a very big mobilization by the health plans and by the physicians themselves, or nurses or other workforce, to meet all the needs of health services that these people have.
Now, one of the issues that is always discussed when comparing the UK's health system versus Israeli health system is the fact that the IT system and the linkage between the hospitals and the health plans is far more efficient and effective in transfer of records and those kinds of things. Has that facility, those IT internet connections, have those survived unharmed, and have those continued to function perfectly well throughout the country, including in the south, where there's been so much of the trauma and so much of the war has taken place?
Yes. So the care provided by the health plans was not changed, and they still provide care remotely. In hospitals, as I mentioned, they did prepare themselves for cyber attacks, so they did remove some of the services that were online, but they're doing that in a different manner, with more security. It's not that they stopped providing remote services because of that. It's just changed the way they do that to be in a more protected way. Is this what you asked? Did I answer?
Yes. So in other words, the IT systems have really come through this unscathed.
Yes, they're running normally, and maybe even more, because there are higher needs for remote services. People are afraid of leaving their homes, or people just lost their homes, so they cannot really go to their own clinics. So many patients are receiving care remotely, as we saw during COVID.
Right, and that raises the question, is that presumably, therefore, evacuees' health records are going with them, or available to the place where they come to. So if you fall ill with a myocardial infarction when you've been transferred from the south to Netanya, you're...
Okay, now I understand. So the health plans, they're nationwide. It's different from the UK, where you have different regions and CCGs, where if you belong to one region, you cannot receive care in another region. In Israel, if you go to a clinic of your health plan in another city, you give your ID number, and the person, the health worker that is taking care of you can have access to all your medical records, regardless where you live. The only problem here is that some people are receiving care in health plans that are not their own health plans, so not where they are members. For example, people from Maccabi are receiving treatment at Clalit clinics, and then they don't have access to the medical records of this patient, because this patient it doesn't belong to Clalit. But it's relatively easy to people to access their own medical records through their phones with apps that the health plans developed. So people can go to a physician and show the physician their own medical records that are accessible by their own mobile phones, because everybody has access to their own clinical records. And actually, these records are very complete. They include all the prescriptions that people received, the results from all the laboratory tests or imaging diagnosis tests, all the visits to physicians, all the drugs they have purchased in the past. So the continuity of care and quality of care is not damaged by this. And this is one of the big strengths of the Israeli health system, that they have such a developed and accessible electronic medical records. And I can tell you, as a person living in Germany, that this is not obvious at all in other countries.
Right. And then I think there's one last question, which is, what about the preparation for the next wave? For example, if there's a ground assault into Gaza, what is the preparation that's taking place within the health system, seeing that is going to be something that's predicted or predictable, and therefore an influx of patients might be on the planned for, if you like.
Yes, yes, the Ministry of Health is in touch with the hospitals, and they are preparing for a next wave. I don't know exactly how, but they are doing that. Now they understood that they have to be prepared for anything, and they are coordinating that among themselves. But I don't know yet what kind of preparations. This is something that is happening during these days, so it's not something I know yet. They are also creating preparedness plans for mental health and rehabilitation for the day after. So there is a clear understanding that this will be the big need for many years after the war, and they are trying to prepare. The main challenge is that is not enough health workforce in those two areas currently, so let alone after the war. And we will have to reorganize the mode of service delivery. So maybe instead of having mental health workers in the health plans clinics, they will be working through the municipalities or local authorities, because they will have to provide care for people in many people in a certain area, regardless the membership to one health plan or another. And there will be different modes of organization of healthcare delivery. We don't know yet how it will be, because the needs are not yet known. We just know that they will be big.
Because when you deal with this kind of preparation and going forward and dealing with the mental health issues, you've also got to consider the fact that you've got children that are removed from their home environment.
Yes.
For extended periods of time. I mean, medical schools, are closed, universities closed, schools are closed. These also affect the health system, and are those kinds of systems being looked at?
So I think that as during COVID, schools are working remotely in many cities. In some cities, school has restarted partially, and this is important. There is already this understanding that the school system is important for the children, even those that are not exposed to the atrocities. But I don't know yet to what extent the health system is preparing to take care of the children. There are those development clinics that are specialized in mental health for children, but they are also understaffed and under budgeted. So this is also something that the system will have to pay attention to. And I think that is still too soon. People are still trying to reorganize their lives, and the system is trying to adjust to the new reality. And the answers to these questions are yet to come. I think that there are not yet a clear organization of this kind of response.
Right. I think that we've asked a number of questions, and you've given us straight answers and about the way the system is organized and reorganized, and about the areas that there are certain areas of uncertainty. And of course, in any war, there is always the elements of uncertainty and unpredictability. I'm going to hand over now to Fiona. Fiona, are you there?
Yes, I am here.
Yeah.
I also don't have a camera functioning this evening because of the technical difficulties, but I'm very happy to speak briefly because I think everybody probably will want to get away. But thank you, David. Obviously, my main task is to thank Ruth. I think that we have all learnt a lot. Speaking for myself, I have. I don't want to rehearse what she's been talking to us about, nor the answer to the question, but I do want to say that it was just really helpful that you put up a slide that described the health system as an island of stability. And I think what you've been able to do this evening for us, Ruth, which has been incredibly helpful, is to provide in yourself an island of calm and objectivity. We know behind that is some real emotional involvement in what's going on in Israel, and the fact that you could provide this overview so calmly and so carefully and objectively is really very helpful, and we're very grateful to you. The other thing I think this evening's session has done is demonstrated the value of Myers JDC Brookdale in producing research and review of very high quality. I'd like to thank, I would say, my colleagues. If I'm allowed to say that, I've been involved with Brookdale for, I can't remember how long, but somewhere near a decade now, I think. But on the call, we've got Bruce Rosen and Michal Laron, and maybe others from Brookdale. And I think what we're starting is possibly, this was episode 1. We need to return to some of the questions that were asked in a few months' time, and no doubt that there are others that you can help us to understand as time goes by. But for anybody who doesn't know Myers JDC Brookdale, it's really worthwhile looking on the website, and we can share that with you perhaps later on. And looking to see, for me, they've always been Israel's version of the King's Fund, so a trusted source of independent and objective information. And of course, they are a multicultural group of researchers and policy experts. So we get the truth from them, and it's an evidence-based truth, not shouty opinion, and really incredibly valuable. So Ruth, thank you very much indeed. I think we've all got a lot out of this evening, and thank you.